everyone, and welcome to today's webinar presentation, Enhancing Perinatal Mental Health Nursing in Public Health Home Visiting. My name is Andrea Bodkin, and I am a Senior Program Specialist at Public Health Ontario, and I'm excited to be here today to co-moderate the session. I'd like to just acknowledge that I am on the shores of Canandaigua, which is the Haudenosaunee word for Lake Ontario, which means sparkling water. And this land is part of the Toronto Purchase of 1805 Treaty 13 territory. As a white settler, it's really important for me to learn about and to recognize the land that I'm on, and to recognize that the reason I'm able to live and work and play on this land is because of the decisions that my ancestors made. I know that many of you are in different places all across the province of Ontario, and I'd like to encourage you, if you haven't had the chance already, to maybe learn a little bit more about the land that you're on, the treaties, the people, and especially in light of the National Day for Truth and Reconciliation on Monday, perhaps consider what actions you can take towards reconciliation. I'd now like to introduce my co-moderator for today, Dr. Susan Jack. Dr. Jack is a professor at the School of Nursing at McMaster University, and she's a recognized leader in public health nursing. Her work centers on developing and evaluating interventions aimed at improving maternal, infant, and family health outcomes. And as the head of the Public Health Nursing Practice Research and Education Program, she's dedicated to advancing both public health nursing practice and education. Sue, I'll let you take it from here.
Great. Thank you. Good morning, everyone. And thank you, Andrea. I continue to be so grateful for this incredible collaboration and partnership that we have with Public Health Ontario, and the incredible support and expertise they provide, which allows us to provide these opportunities for professional development to public health professionals across Ontario. I'm here today representing the work of the PHN prep team, but I'm also here today to begin to introduce the work of the Provincial Perinatal Mental Health Working Group, which over about the last 18 months, this working group comprised of some of the most exceptional public health nurses, supervisors, managers, and directors across our province who have come together to share their knowledge and expertise on the topic of how can nurses recognize, assess, and respond to the mental health needs of the clients that are served through the province's Healthy Babies, Healthy Children and Nurse Family Partnership Program. And it is our plan over the next year through these webinars to focus on the topic of perinatal mental health. And today our focus is going to be having a starting conversation, thinking about the role of public health nurses in addressing perinatal mental health and in exploring some of the current challenges that exist for many teams or health units in responding to this issue. And we really hope that this will just be a starting point of a conversation across the province. And because this is going to be a conversation today, all of you will see on your screen that there is a Q&A panel and a Q&A place to post questions. So please, as we're talking and chatting, please also post all of your questions that you wish to ask the panel. And what I'm really excited about also over the next few months that will build on this conversation is that we will be sharing and disseminating with all of the HBHC teams in the next couple of months the provincial nursing care plans and guidance that the working group has been working on. And we recognize there's a lot of resources that can support healthcare professionals in understanding issues of perinatal mental health concerns. What we really identified through some of our evaluations that is a key gap across the province is what is the role of nurses? What does recognizing, assessing, and responding to perinatal mental health look like when it is conducted by a public health nurse within the context of home visiting. And that's really the gap that our working group has set out to address. So this is just a little bit of a teaser to stay tuned that some really incredible resources are going to be coming out in the next month. But to kick off this conversation, I'm really excited to introduce the members of our panel today. And we have four public health experts, I think public experts in public health nursing and mental health, who will join us in our panel conversation today. And I'd first like to introduce Christina Bradley, who is the co-chair of the Provincial Perinatal Mental Health Working Group. And Christina is a public health nurse with the Family Health Division with Niagara Region Public Health and Emergency Services. And she brings over 25 years of experience in supporting families through a range of outreach services. And I would say over the last 18 months, my own knowledge around the assessment and response to perinatal mental health outcomes has increased exponentially, and it is all because of the learning that I have taken away from my work with Christina. Next, I'd like to introduce Cynthia Clark. And Cynthia is a supervisor at the Halton Region Health Department, and she has over 27 years of mental health experience. She holds a degree in psychology, a Bachelor of Science in Nursing, and a postgraduate diploma in clinical behavioral sciences from McMaster University. And it's been many years ago, I think, when I first met Cynthia in person, and probably over a decade ago. And one of the things that always stuck with me from those first meetings was Cynthia's commitment to supervision and her ability to listen and hear the concerns of nurses and to support nurses in doing what is often very challenging work. So I'm really glad that Cynthia is also on our panel. Next, I'd like to introduce Denise Sozia from the Thunder Bay District Health Unit, and another public health nurse who serves as the prenatal lead at her health unit and has a really strong passion for perinatal mental wellness, currently pursuing her master's degree, and really excited that you will come along with Christina to speak from the perspective of public health nurses on our panel. And lastly, really thrilled to introduce Tricia Hardy, who is the program manager for Healthy Families at the North Bay Parry Sound District Health Unit. Tricia has over 30 years of experience in home visiting, both in nursing and management. She's worked across, I think, five public health units, so has a really deep understanding of home visiting, of HBHC and its roles within public health. And she has worked in supporting families across diverse geographic settings. And I should have done the math earlier, but I think, collaboratively here, there's well over 100 years of public health nursing experience together on this panel. And I will identify that Sharon Couson was also going to be part of our panel, but she is unable to join us today. So the format today is going to be a discussion, and we're going to kick off the discussion. I'm going to ask our panel members some questions to respond, and I will be keeping an eye on the Q&A, looking out for all of your questions from the audience. Again, and the focus is just about starting this conversation on how can nurses and teams, HBHC teams, support families who are experiencing mental health concerns in the perinatal period. And so, Denise, I'm gonna start with you. And the question that I want to ask you: why are public health nurses who work in home visiting programs like HBHC or Nurse Family Partnership, why are public health nurses uniquely positioned to recognize and respond to perinatal mental health issues?
Yeah, so I think first and foremost, in my opinion, the HVHC nurses are exceptional nurses and human beings to do the work that you all do. But I think ultimately it has a lot to do with that unique approach to care with their clients and families with the in-home visitation. They're exceptionally positioned to support perinatal mental health because of that, because by visiting clients in their homes and genuinely meeting them where they are at, PHNs can gain a really in-depth understanding of the family situation. You can facilitate those real-time discussions if you're, noticing things within the home, especially about around perinatal mental health, and you can provide that supportive discussion in a environment that's comfortable for them, where they're comfortable to potentially voice concerns, and that enables the nurse to have that prompt intervention. Also, the specialized training that HVHC nurses have to effectively recognize, assess, and manage perinatal mental health issues is very different from just the very brief episodic care that primary care providers provide to clients, or even those of us in health promotion sometimes just have really brief interactions with these families. Just that consistent support is really important too. They can build really long-term trusting relationships with clients, and they gain that trust to help them navigate, persistent issues, especially related to perinatal mental health. They can also help to facilitate referrals when they know their clients are struggling to do that. They can connect families to community resources that they may not be aware of. So it's really that level of support that extends far beyond the traditional healthcare setting, I think.
Great, thanks, Denise. So
Mhm.
really, two of the things that I've really picked up on your response is that um, some of the benefits of a public health nurse and home visiting is a consistent approach. And really the benefits of those ongoing relationships and being able to assess people within the context in which they live. And I'd like to open this question up to any of our other panel members, really to think about within our healthcare system. There are many different providers who, within their roles, will see it as part of their responsibility to assess for mental health, and perhaps to intervene. So again, as we think about what's the unique role specific to Healthy Babies, Healthy Children within that broad healthcare system, anyone else have some other insights around what is unique about the perinatal mental health provided by PHNs that augments or expands on the care provided by other primary care providers or mental health specialists? And I'll open that up to any of our panel members.
I think that, like, just in addition to what Denise said about working together with community partners, I think one of the things that community partners try to do is to come up with a bit of a plan for how to support both the parents, the family, and perhaps the infant or child as well. I think that one of the pieces that nurses have, and it goes back to being in the home, is we can lend a bit of perspective about what is a feasible plan. So sometimes, I think we have families or other providers saying that they'll be there for X, Y, and Z in terms of their part in supporting the family. And families are vulnerable in that state and may agree to things that they may not actually feel like they can follow through with in the home. So I think that's like sort of an additional unique lens that nurses can bring to that kind of community plan is what is actually feasible, what is the family actually going to be able to engage with.
Yeah, yeah, because if things are feasible, then they're more likely to be taken up and actualized for the family. Cynthia or Christina, any additional thoughts?
Well, you know what? I will just add their expertise in service coordination, bringing that strength-based aspect and role modeling that for other service providers, always keeping the family's wishes in front so that we are supporting them with what they need when they need it. And HBHC nurses and home visiting, it's a big part of their role. They're very skilled at it. And then it helps to support that family to move forward to meet their goals. When we can all take a piece of that role, understand what our role is in working together, and help move that family forward together.
Yeah, I'd really like to endorse what you just said about that strength-based approach. Over the last week, in my normal role as a researcher, I've just been reviewing and analyzing interviews with graduates from the Nurse Family Partnership Home Visitation Program. And in reading mothers' narratives of their experience in a home visiting program, what really struck me was that in comparison to almost any other health or social care provider that touches their lives or provides support, what is unique about the public health nurses' roles is that they are there, they don't just come in to address a crisis. It seems that everyone else comes in at a moment of crisis and focuses in on that crisis issue. And what has been really unique in this data set is mothers saying the public health nurse is always there. Right back to Denise, what you said, it's like we're there as that consistent person that is highlighting their strengths and not only starting to intervene because someone has identified a deficit. So I think that's so critical for all of us to think about as underpinning our practice, that consistency and that strength-based approach. Christina.
Yeah, I think that home visiting nurses are, again, just seconding that they're so uniquely positioned to have frequent contact with clients, to really establish a therapeutic relationship, and to because there's still a lot of stigma around mental health and perinatal mental health and what parenthood is supposed to look like and feel like. um, you know, Home visiting nurses are in that unique position of early recognition, right? And early disclosure of thoughts and feelings and emotions and struggles. And I think as home visiting nurses, speaking to those pieces of case coordination and referrals, like sometimes the first kind of discoveries of mental health concerns might occur within the home visitation context before even like a primary care provider might recognize during an appointment. So I think it's very valuable for nurses to have that opportunity to have those frequent contacts and notice changes and things like that, just because of the frequency of visits.
Yeah, again, another one of those benefits of that ongoing sustained relationship. And you've really also highlighted the unique perspective that public health nurses have the opportunity to identify challenges within the context of supporting individuals on their journey of parenting, right? So it's, it's another complex layering of not only beginning to understand how mental health concerns impact the individual themselves, their thoughts, feelings, and behaviors, but then also understanding what influence that may have on their parenting of their child or children.
I
Okay.
just have one other little piece to that, which is everybody's sort of talked about trust and the value of trust. And I think the other piece that nurses are well positioned to do is to bridge that trust to other providers. So, that's one of the things that we try to do, and we encourage families to reach out or to receive other services. And I think we can help in some little ways to bridge that trust so that they're accepting.
Mm-hmm. And it speaks to the importance of public health nurses, the credibility in the community and their competencies as advocates, right? So not only advocating for changes at system levels, but advocating for families and supporting families to identify what their needs are and nurses' role in that work. Now, as we've worked with the mental health working group and through PHN Prep, as we've done ongoing evaluations over the years, one of the things that we've recognized that I think is a reality that anyone here today knows as their day-to-day reality is that the composition of many HBHC teams has changed since the pandemic. There's been retirements, nurses and managers have shifted into other programs or teams. There's many new nurses on HBHC teams, and some of these nurses are new to public health. So we appreciate across the province that there's great diversity in amongst the knowledge and skills of PHNs on HBHC teams. So my next question is really related to education and training. And Denise, you already identified that public health nurses, many of them have expertise in mental health, but as new nurses come to HBHC teams, I'm wondering how can teams support all the nurses on the team to sort of have a baseline of solid knowledge around mental health, the types of mental health concerns in the perinatal period, the health effects, how that influences parenting. So, from across the province or on your teams, what are some of the standard training opportunities that in your health unit have been promoted to create that expertise amongst public health nurses? How about Cynthia?
Sure, I will start with that. I feel, pre-pandemic, we did do, I was a mental health first aid instructor for the Mental Health Commission of Canada. So I did implement that for our division, but of course, many people have come and gone in our division already. And we all have done assist in the past, and we're all looking for new opportunities to renew some of that. But I think the other thing that we've done really well is mental health is an everyday conversation. It just isn't a 2-day thing taught once a year or once a decade sometimes. It is an everyday conversation that you bring into every conversation. We talk about it as part of our reflective practice. So we just don't box it into a few days or 1 day a year and talk about it when Bell does their initiatives or anything like that. It is something that is ongoing, and we talk about it all the time because we have to look at our own mental health as well as we reflect on how we respond to our jobs. So our response is in direct parallel to how our clients are feeling and acting as well. So we have to look at mental health holistically and make it an everyday conversation. So not to say that we wouldn't continue with, ongoing mental health initiatives to augment that as well. And we're looking for those opportunities as well.
Mhm. So building on that, within the culture of your team in Halton, what have been some of the strategies that you've used to really create a culture where those mental health conversations happen every day, where it's not just it's the let's talk day? Are there, and again, it's just I think this is a great opportunity to share some best practices with other health units who might be thinking about, well, how can we create that type of culture?
Mm. Well, I have to say I've been very lucky in Halton because we had a whole mental health team and a mental health promoter previously. So I have had nurses that are actually trained in CBT up to level 3 and in group. So, but having a strong foundation in motivational interviewing has helped to support those conversations around mental health as well. So I think that was part of it. We inherited people that focused on mental health. We brought them into the team, and it just became part of and embedded in the culture that we do. We talk about mental health of ourselves and mental health of our clients. So really embracing mental health on a continuum, right?
Okay.
And what the Mental Health Commission of Canada would say, and give the opportunity to participate in those things and further advance our own learning.
Okay, great. Thanks, Cynthia. And Christina, what has been the work at Niagara Region around supporting staff and nurses to create sort of that foundational knowledge around perinatal mental health?
So similar to Halton, our staff are encouraged to take assist training in addition to safe talk. And really that reflective practice piece, I can't agree enough that that's really a core component of understanding perinatal mental health, possible transference. We support clients with experiences of trauma and grief and the impacts that those have as well. We also do like a perinatal mental health orientation if you're joining any of our early years teams. So whether that's Healthy Babies, Healthy Children, Nurse Family Partnership, or our Healthy Child Development programs. And in addition to that, we have some really strong like policies and procedures in terms of suicide risk assessment, how to assess for risk of certain mental health concerns, and nursing care pathways to be able to support in some of that decision making of, okay, where do I go next with this client? And, are my concerns, strong enough, and based on my clinical judgment, do I feel that that client needs to be connected with a healthcare provider? So we have those things in place to support our staff as well.
Great. And if some of the teams out there are not familiar, could you just briefly distinguish or describe what is Safe Talk and Assist? Because I both you and Cynthia have mentioned Assist.
Yeah, they're both suicide risk assessment and suicide prevention training. One is a little bit more, I would say, of an overview, and the other one goes into a little bit more detail in terms of recognizing risk for suicide, determining thoughts from intents and plans to act, and when to connect people with additional support and services. And both of them emphasize the importance of it's okay to ask an individual if they have thoughts of suicide. Do they intend to act on those thoughts? Do you have a plan? Do you plan to act on that plan? And that does not increase suicide risk. So I think that would be the commonality, but one is just a little bit more in depth than the other. Would you say the same, Cynthia?
I absolutely would. Safe Talk is really about getting comfortable with the conversation around suicide and the language around suicide, and destigmatizing that and saying it's okay to have a conversation about this because we need to put it out in the open if people are feeling that way. Assist, and there's several levels in between there. Assist is about intervening, about the ability to intervene and contract with the person and or get them immediate help. So it assesses the immediacy and the risk of the person who is talking about suicide. So those are important skills to have, but they need to be ongoing skills, because if you don't have those conversations every day, it feels very foreign and very scary to people to that. So it needs to be an ongoing conversation. And like Christina, we've done a lot of the same work that she has, in addition to having corporate-wide initiatives around Not Myself Today and other avenues that people can take outside of our team to learn a little bit more about mental health as well. But yeah, it needs to be a strategy, and it needs to be comprehensive for it to make a difference as well, for people to understand mental health on a continuum and embed it within their programs. It needs to be made live.
Right. I think that might start to be a common theme today about the importance of it being comprehensive, threaded through everything, and that we cannot continue to just rely on mental health one-on-one, 101 workshops, or these just sort of one-off things, right? If there's not the infrastructure back within the health unit to support it through all actions, right? Through practice, through policy, through supervision, then it doesn't get taken up effectively. Denise, what's happening in Thunder Bay? Is there any sort of standard training that supports nurses to develop, as what you highlighted, this great expertise that nurses come with understanding the importance of mental health?
So I feel like a bit of an echo from what was already said. So mental health, first aid, assist training, safe talk, that importance of reflective practice. Specifically, if we're talking like specialized courses and workshops, our HPHC staff do go through training from Postpartum Support International. So that also is improving and deepening that understanding of perinatal mental health. They also take some specialized courses and seminars through the Parent-Child Relationship Program at the Barnard Center. It's through the University of Washington. So there's a Promoting Maternal Mental Health During Pregnancy course, and a parent-child interaction workshop that our staff completes as well, just to further support that understanding.
Great, super. And Tricia?
I'll be an echo as well. I think in North Bay, Perry Sound, we have all access to all of those trainings and do them on a regular basis. One of the things we think about is about sustaining the training, right? Like somebody else mentioned, there is like it can be a turnover of staff and that kind of thing, but the other part, like we've sort of built it into a comprehensive package around orientation. We've developed, like the team has developed a competencies list and then linked to the competencies, they've learning resources as part of sort of the formal kind of training with that. The other part of it is, I think, is to recognize the expertise within your team, to really value the expertise that team members have had in the field, like when the rubber hits the road, and the sharing that happens within the team, and the consultation that can be so valuable from a peer that might differ from with a manager or what have you. The other part of it is a little bit of work with the differentiating the roles with the PHN and the family home visitor. Sort of at times the family home visitor role might be put on hold, sort of in a sort of an acute situation. But what we really tried to sort of talk about is that families are parenting while they have a mental health challenge. That part doesn't go away. And so recognizing how having anxiety or depression or even distortions in your thinking can really impact, the ability to learn or to sort of implement some of the parenting skills, and just even to be present for interactions with your infant or your child. So that's something that we've put some emphasis on as well. And the other, so whether it's a learning strategy, I think is, the screening, and then the piece that the community provides around referral and pathways is keeping that up to date for nurses in our field, because we don't have a lot of resources in our area, and things change with them. And so I think that's another part of the learning that we try to keep up to date, so that people have know what's available and what's involved in getting families connected to those services. But the competency list exercise was really a good one for us, because I think people were safe enough to say what they didn't feel confident about or didn't think they had enough knowledge about, or skills. So that was a really kind of, I think, a meaningful piece of putting together like a package, so to speak.
Okay. You may be getting a request for that example of that competency list exercise, and maybe we can share that provincially. And yeah, Cynthia.
You know what? I would be remiss if I didn't mention our early years team, because our early years team really supports our HPHC team. They provide wonderful neighborhood groups and HPNP, but their focus is on early years mental health, and they've just done a wonderful ACEs learning package that all helps to support us in understanding mental health and its impact in the early years and its impact on parenting in the environment. So they play a really complementary role to our HPHC team. So I really wanted to shout out to them and how important they are to us.
No, great, thank you. And it's a reminder as well that we don't do this work alone, right? That there's every different profession, team, group has different skills and knowledge to share with each other and to learn from each other. And I'm looking at the question pod right now, and so I'm just going to skip over to our question and answer pod. And I am not surprised at the first questions. Christina, as soon as you started to talk about some of the resources at Niagara, I saw this question pop up, and it says, are there nursing pathways and risk assessments internal to the organization of Niagara or available for other organizations? And I want to say thank you for asking that question. The answer is we, in November, we anticipate in November at our webinar here, and it'll be a webinar, we'll be engaging Christina Bradley from Niagara to introduce nursing care plans specific for public health nurses for supporting perinatal mental health. This has been the work of the working group that I've mentioned that over about the last 12 to 18 months did a comprehensive review of the evidence, a review of the literature. We asked health units all across the province to send us all of your pathways and resources. because we know it's important not to reinvent the wheel. And ultimately, the pathways from Niagara region were selected to be adapted and enhanced. And we will be disseminating a framework to support specifically public health nursing care and care plans grounded in the nursing process and detailed guidance in November. So this is just to let everyone know that these resources are coming. And there are very detailed nursing care plans for the recognition, assessment, and response to anxiety, depression, suicide, perinatal psychosis, and homicidal ideation. And along with those nursing care plans, guidance has been written along with strategies of what tools to use, how to administer those tools, how to score the tools, how that can inform your nursing actions, as well as the nursing interventions that you as nurses can implement in your work with families. And these tools have been piloted by HBHC teams at 4 health units. Thank you so much. And from those 4 health units, they've also shared with us examples of scripts and strategies on how nurses can integrate this. So yes, everything will be shared this fall with the teams. And then Trish, someone else had asked a question as well. Are you able to share the competencies you've identified? And I'm wondering if that is a tool that's shareable, if you could share it to me through PHN Prep, and maybe we could look at that. This might be one resource that we could add in this package of resources that we send out to all 34 health units.
Yes, and listening to sort of your description of the sort of good work that is going to be available to everyone, I would imagine, a competency sort of profile or checklist could be augmented. I mean, we were working with what we were able to do independently, but I'm really looking forward to seeing that the entire sort of repertoire of resources that we'll be able to access through the training. So I'm willing to share it now, but I'm sure you're going to want to look at it in the context of that.
Absolutely. Because, as you're speaking, I thought, wow, that would have been we should have created a list of competencies. And as we continue to develop some educational resources to support the guidance, then certainly that'll be something that we will work and ensure that everything here will be shared province-wide with all 34 teams. Now, Cynthia, someone else has asked in the pod that you mentioned about a early years team that supports HBHC. Can you share about who they are and how they support your team with this work of perinatal mental health?
Well, I'm sure they'd be better to speak to it than us, than me. But that is partly of what they will be focusing on and continue to focus and build on. How they support our HBHC team is we often, our clients are part of their groups. So as we implement our family service plans and as we near maybe the end, or if we identify that there may be something a client needs, like they're socially isolated, we may refer them to one of their neighborhood groups. And those groups are for parents who have multiple and complex needs. So they're often the groups are filled with HBHC clients. And they have nurses there that are there to support them, and the kids can go as well to the neighborhood groups. So it becomes a community, and that community is supported by a public health nurse. And it's a really good strategy and connection for our families to get them out of the home, meeting other families similar to theirs in a really nice environment. So that's, we really work together on those. And sometimes if we share the same client, we'll do some service coordination pieces as well. So make sure that we're surrounding the client with what they need.
Okay, great. Thanks for clarifying, Cynthia. And as I'm looking in the questions, and several of you have already started to reflect on that this can be challenging work for nurses. Cynthia, you alluded to the importance of having conversations about mental health, the mental health of of the provider and nurses, and having those conversations as part of reflective supervision. So I want to jump ahead a little bit and maybe ask some questions around reflective supervisions, recognizing that for HBHC nurses, many nurses have large caseloads. The acuity of clients, the number of complex needs of clients, this all adds to the challenging work that public health nurses engage in with families. And so what does reflective supervision look like in your health units? How is it provided to public health nurses? And particularly if any of you can elaborate on this intersection of reflective practice and the provision of perinatal mental health care. And maybe I'll pose this first to you, Tricia. Just some thoughts around reflective supervision around this topic.
I think, I mean, we've sort of talked about how challenging this work can be when we're in people's homes and we are seeing sort of some of the challenges in their day-to-day lives. And when we're in sometimes the only provider that is involved with the family in geographies where there's not as much resources available, I think we can nurses often will experience sort of the feeling that they're all alone in supporting a family, and whether that's sort of a longer term kind of involvement in supporting a family or in an acute situation, in a crisis situation. I think nurses really feel right for families that are going through this, and sometimes feel may not recognize the value and the impact of their sort of unconditional support and working together with them on trying to improve things. So I think helping as part of the reflective supervision to help families or help nurses, excuse me, sort of recognize their strengths in the situation and what it is that the impacts that they are having, which may be little or may feel invisible when you've got this sort of heavy feeling about sort of responsibility or concern. And I think that, the other thing, people have talked about the potential for harm for the parent that's experienced mental health, but in these situations, unfortunately, sometimes parents can have thoughts of harming their infant, which is a very scary thing to experience. And I think for nurses, it's a scary thing to hear. And they may, again, with that responsibility that we have around making sure kids are safe, be torn between the obligation for child protection, for reporting concerns of child protection. And I think, and feel as though are worried that might make it worse. And I think nurses require support to sort of work through that in the moment. But also afterwards, nurses will ruminate, as we all do, what could I have done differently? What could I have done better? And then trying also to sort of understand, what's going on internally with the nurse in terms of their response especially to an acute situation, but even to sort of a more chronic situation can be a bit of a different impact. So I think that part is really important to give nurses an opportunity to talk about that in a safe way, in a non-judgmental way, and with a real emphasis, I think, on people will say, I should have done this, I should have done that, and in that they're saying I made a mistake. And I think the one thing that, the one message, whether it's in the context of perinatal mood disorder or any other challenging situation that nurses face in home visiting, that sort of to understand that any situation where they're reflecting and feeling as though they may have done something different, the important part of that is a bit of forgiveness and understanding about that, but also to sort of really think about what they might not only do moving forward, but how they might perceive sort of their role in it. And part of going through that kind of a process, I think, helps to improve confidence for the next time. And the last part of that, I think, is about exploring kind of the willingness of that nurse to share the experience for the benefit of learning with others. And I think that it's hard to do that when the nurse is feeling vulnerable. So if you can work through some of that and share that. The other thing is, when you with the team, obviously the team support with that is really essential. So I think really recognizing the hard work that the hard stuff, right, that we see and experience, and we may have a bit of powerlessness, like perceive that. All of those, it requires a lot of support and also work, right? The nurse has to work through some of that. And I think validating that and supporting that is really an important part of doing this work.
No, thank you. And I mean, you've spoken of elements of forgiveness and essentially nurses being kind to themselves and repair work. And just, as you were speaking, within your work and your supervisory role, have there been times you've provided anticipatory guidance to nurses to think about if they need to support a family to be engaged with children's aid, how they do that in a way that's trauma informed, so that it is stressful and perhaps traumatizing for the family, but how to minimize some of that potential harm for themselves worrying about it and for the families.
Yeah.
Guidance to nurses on how to do that well.
I mean, so I think, again, we practice a lot, right? In our team, we practice sometimes about how to sort of have like difficult conversations, period. And one of the things that the nurses repeatedly say is they appreciate little scripts, right? So when you're in the moment and your sort of amygdala is firing and maybe you're not able to sort of problem solve, that you have that, you have some of that to call up. And I think in terms of working with CAS, again, that if we have the benefit of a longer relationship with the family, and the concept of bridging some trust to the service, and just sort of really acknowledging the courage and the for both the family and also the nurse that's required to sort of to do that. So I think that rehearsing that, the other piece that I think is important is if you're able to sort of engage with CAS ahead of time, it just in general, how are we handling these kinds of cases? How are we ensuring that children are safe? How are we working towards bringing everybody back together? And some of the service coordination that goes on in between, in areas that I've worked where that's been in place, including CAS representation on perinatal mood disorder community tables. All of that sort of gives everybody some confidence about what the response will be, because the reality is nurses are always, not always, I just did the distortion, that they're often worried about. So I know I have to make this report. I don't know what to expect. I don't know that I'm always going to get the response that I feel like should happen. And those are the realities. We need to talk about that, and then to build those relationships with the CAS workers as well, so that you can begin to have, I think, more confidence in how that's going to play out, which translates back to working with the family, right, and engaging them in getting the supports that they've now opened up to be able to receive, hopefully. So.
Oh my gosh, thank you. Such important strategies. And it also aligns with what you shared earlier about the importance of keeping up to date the referral pathways, the information about who are the partners in your community, so that teams can be working with them to understand how other services and agencies work, and you have that anticipatory guidance to be able to provide to clients as well. And Cynthia, I'm going to pose the same question to you as well. And if you could just share with other health units, what have been some elements of what reflective supervision looks like in Halton that may be emulated or taken up by new supervisors or managers in HPHC programs across the province?
Yeah. So reflective supervision, dear to my heart. It's just one part of the supervision that HBHC does. I mean, admin and clinical being a really important part of that. But reflective supervision is really, for me, about creating that psychologically safe environment for the PHN and myself to have those conversations, those really hard conversations. And those easy conversations, fun conversations, hard conversations within the context of the relationship, built over time, built on trust, built on the ability to repair if something goes wrong. And that ability to externalize those feelings and take a step back from the work and take a look about how is that work impacting you as an individual and a practitioner, because we all come to the table with our own baggage and it impacts our work. And although they do such a good job out there in the community, it, giving that opportunity to allow us to talk about it, externalize it. And once it's externalized, we can do something with it. We can't do anything with it if we internalize it. It will come out. It will come out in illness. It will come out in nutrition. It will come out in different ways. So creating that environment over time, a parallel process with what they're doing with their client out in the community, is a really important part of the work in working with clients who are exposed to trauma, and we're exposed to the secondary trauma of that. You know, it is an opportunity to grow the relationship, but it is also an opportunity to learn from each other as well. So as we're able to uncover some of the feelings, uncover some of the issues, ask questions, we both grow and learn over time, and that just strengthens that relationship. We do, it relates to reflective practice, and some of the same principles that we can apply there is that, coming together as a group to learn from each other, and to be curious, not judgmental, right? So that when we are curious, there's opportunities for us to grow as a group and support each other as well. So it's a really, really important part of this work that we are able to externalize and have these hard conversations and repair conversations as well, like Tricia said. So it is developed over time. It is a skill to be learned. And there is lots of literature out there on how aspects of reflective supervision, and it's just a different way of thinking and doing things.
And can I ask at Halton, do you have regularly scheduled one-on-ones, or are they one-on-ones with nurses as needed, or is it group-based reflective supervision? And I ask this question imagining that there may be nurses or managers listening today who are like, how on earth do I have time given all my other responsibilities and a large team of HPHC nurses to do this work with the depth and sensitivity and skill that's required?
It's a great question, because it does get challenging sometimes, but we do have regular one-to-ones, and I feel that's a necessity for us to be able to connect and do that stepping back from our work, but also do some planning forward as well. So we have regular one-to-ones every 5 weeks, and we do have regular reflective practice meetings, usually monthly, where we get together and have that opportunity to learn and grow from each other, because they are the experts there working out in the field. So they have so much to learn from each other, and I have so much to learn from them as well. So that is how we're able to work it in Halton, and it's been a really good model for us. We were able to take our 2-day CBT training and use the reflective practice meetings that we had to have them specifically focused on CBT skills for a while, and then start to overlay some of the other things like, how does that fit with MI? How does that fit with TVIC? How does that fit with trauma? How does that fit with our directives that we have to do, NCAS, promoting maternal mental health. So we've had some really rich discussion, and we're really able to move things along.
Great, thank you. Now I'm going to turn from a nursing perspective. Denise, do you have opportunities in Thunder Bay for reflective supervision and opportunities to have conversations about both the rewarding and challenging work of nursing?
Yeah, I think echoing just what's already been said, there's definitely that opportunity for reflective practice. Also, even just from an informal perspective with peers, a more formal group reflective practice, and debriefs, and that manager support specifically for handling those challenging cases, offering guidance, and how to navigate that.
Great. And Christina, any last thoughts on the value and importance of reflective supervision, or some insights on what models look like that you've experienced in your work?
Yeah, so we're really fortunate that both Healthy Babies and NFP have these extraordinary team leads, like a huge shout out to them. They're the ones that take that lead on reflective practice. And so they have book times where they will meet with staff, mostly founded on the Gibbs reflective practice cycle. And again, an opportunity to kind of unpack what are the emotions that came when during that particular experience with a client. What are your thoughts? What might you do differently? What did you think went really well? And so to have that regular, like, protected time in your calendar, I think is really important. And they're very skilled at doing that with staff. In addition to that, they're available like ad hoc. Our leadership team is available kind of as needed. And then sometimes for those more clinical pieces, right? Sometimes it is those case consultations, whether that's with leadership, a team lead, or as mentioned earlier, maybe a more experienced kind of a mentoring nurse to kind of tease apart what's going on and take a look at some of those clinical components. But it's nice that we have that dedicated kind of protected time for reflective practice. I think that really makes a difference in the work that we do.
I agree. I think that when organizations commit the resources to protected time, it's one way too that organizations are indicating a value on the well-being and mental health of their workforce, and a recognition of this hard work. Now, you've mentioned the Gibbs cycle, and there is a question in the question and answer pod around if any of you have other recommendations for models for supervisors on conducting reflective supervision. Gibbs is a common framework. Cynthia?
We use Gibbs as well. We've used that for a long time. It is based on thought, feeling, actions, right? It mimics a CBT. So we use that for reflective practice. I think your resources on PHN Prep, you've got some really good resources on there on reflective supervision. And I think if people were wanting to start to learn there, that would be a great opportunity to look at PHN Prep's resources on reflective supervision and the references in there to start a conversation.
Great, thank you. And those are on phnprep.ca under resources. There's practice guidance resources. So thank you, Cynthia. Okay, I'm going to switch. I'm going to switch tactics because we're here till 11, but I'm going to raise another question or topic that there's been a lot of discussion across the province. Whichever health unit that our team goes to or that we're connecting with, we hear about CBT all the time. And we hear that some health units have incredible supports, resources, training. They're offering group CBT. They've got different group and individual CBT. Other places, I hear people saying they're using psychotherapeutic skills. And so I think across the province, there's some challenges in language, term, understanding. And I'm wondering if we can start the conversation today to think about, there's been a lot of discussion in the field about the difference between cognitive behavioral therapy or CBT as a psychotherapy intervention compared to using CBT skills as part of nursing care. And Christina, can you start us off on trying to demystify or explain these two concepts for all of us?
Sure. This is probably going to be quite an oversimplification. So cognitive behavioral therapy, CBT, is based on the premise of, you have that component of cognitive, which is a client's cognition, their thinking, and B is for behavioral, right? The actions that they take. So CBT is a structured form of psychotherapy. and it's a psychotherapeutic intervention that proposes that when there's dysfunctional or distorted thinking, that impacts your feelings, your emotions, as well as your behaviors and your actions. So, through case conceptualization, exploring an individual's lived experience, their childhood experience, how does that create maybe adaptive and maladaptive thinking, whether that's at a superficial level, automatic thoughts, whether that's more at an intermediate belief, like underlying assumptions, or their core beliefs or their core values about themselves, others, or the world. And so that itself is psychotherapy. It is a controlled act with a CNO. Yes, nurses can do it, but it's with certain components in place, including clinical feedback and clinical supervision. So for some health units that engage in group CBT, that is a very structured curriculum approach. It is a psychotherapy group intervention. You undergo supervision before you can implement independently. There's communities of practice generally involved to support ongoing skills development. And so across Ontario right now, that exists in a variety of forms, whether it's a 1 day or a 9-week, really focusing on perinatal depression and anxiety. Niagara also offers a 10-week for a very specialized population. So that's a little bit different than like the PHN role and home visitation, where significantly our work is, supporting again that parenting piece and working towards the family service plan. So what we do know is that cognitive behavioral therapy and the concepts of cognitive behavioral therapy is some of the leading interventions to support individuals with perinatal depression and anxiety. We do a lot of this in our work, and those things are not necessarily controlled acts. So if we are finding that a client's mental health is maybe getting in the way of reaching and achieving some of those parenting goals, they might be on a wait list for service, or they are receiving service from a qualified practitioner in mental health, sometimes we can offer those additional supports within the home. So we draw from a variety of resources to do that, whether it's the Promoting Maternal Mental Health curriculum, or whether it's that 2-day CBT skills base from Dr. Ryan Van Lieshout. What those are is just a collection of evidence-based strategies that nurses can use along with motivational interviewing to support mental wellness within the home. So we know, what I kind of think about it is, when you go through that 2-day training, we know that there are some strategies that are just more impactful in the perimental period than others. We recognize that self-care is really important. Nurses teach about, self-care all the time. But if we take a CBT lens to it, then that might be, let me be as evidence-based as possible and suggest some behavioral activation to help with depression and get you out of the house and doing things that you love again. Or if there's going to teach relaxation strategies for managing anxiety, using that CBT framework, what are the best, most evidence-based relaxation strategies, right? Such as progressive muscle relaxation or box breathing, that has a lot of research behind it, so that when you're introducing these, techniques to clients, which we've been doing for years, they're just a little bit more, have that more evidence base behind it, specifically for that perinatal mental health period. So I think kind of broadly, that's that distinction. Within the 2-day training, however, we do, there is a component around thought records. So thought records, because that is the recognition that there might be, again, some distorted thinking. It is a very structured approach to teach individuals to recognize their distorted thinking, do some cognitive restructuring, generate some perspective, and balance out their thoughts to decrease the intensity of their emotions. That does enter into that controlled act, which again is okay. Nurses can do it provided that there's clinical supervision, but thought records are not applicable for all clients, right? So we would recommend like policies and procedures and guidelines to be in place to recognize when that particular strategy would be helpful and or harmful to a client. So I hope that kind of sums up in a nutshell those distinctions, and feel free anyone to add to that.
Yeah, thanks, Christina. And I wrote down, because I too struggle with the language, that within home visiting, what public health nurses can use with this little bit of training is its evidence-based strategies to use alongside motivational interviewing to support and promote clients' mental wellness. So thank you for that language around, that these are evidence-based strategies. And you've already started to talk about thought records. And I think this is really maybe another important point to emphasize to teams, that thought records are a common type of these evidence-based strategies drawn from CBT that some public health nurses have received training to use in their practice. And Cynthia, I'm just wondering if drawing on your expertise, if you can speak to us about when and how and with who a public health nurse should be using thought records with, as well as maybe under what conditions would it be inappropriate for a public health nurse not to engage in using thought records? Because I think we need to be mindful that these are psychotherapeutic techniques and strategies.
I'll just say, Christina, you nailed that. Thank you very much. That was fantastic. And I will put out there, when this came along, CBT, it was very confusing for nurses, but it's very confusing language for clients as well. So we sometimes shy away from using, and we talk about thought feeling activities, thought feeling records, and we do some education around how our thoughts leads to our feelings leads to our action. And we look at that, some teaching around that connection, because it is very confusing, and we don't want, by the nature of us going in weekly, for a client to say, oh, I'll do my therapy with you because I have this really good relationship with you and I don't have to go out of my home, and they may be working with another therapist. So I don't want that to be a confusing piece, right? So if they are working with a therapist on their mental health, which we are not working on, we're working on how it impacts their parenting, we would be very cautious in doing a thought record if they're working with a therapist going through, because I don't want to impact the integrity of that relationship they've going. So we would coach them to say, hey, have you, if there's an issue outside of our scope, talk to your therapist about that. They may have some insight. You may be learning strategies with them that you may be able to address this piece as well. We keep it very much focused within the scope of HVHC, which is on parenting capacity and learning. So that's why, Christina, I think you absolutely nailed that. So that's one circumstances where we'd be very cautious in using a thought record. And it is, again, based on the practitioner's competency and skills and knowledge around and confidence in using thought records. And we may have all of that in place, but then we need to reflect on, but should I use it with this client? Right? So if this client is with a therapist, you have to consider, well, it may be not the best idea. And there's other circumstances where I'm less likely to use a thought record and go to a less intrusive things like behavioral activation. And it depends. I'm not in the room either. So it is the nurses that have to make these judgments. But with somebody who is not able to regulate their emotions, I don't want to do a thought record and leave them triggered and leave, right? That's not good practice either. So I'm very cognizant around that, and knowing your client, that if they can't regulate their emotions, they don't maybe have supports in place, they're not accepting of referrals, they haven't reached out before, and they've got some, significant mental health pieces going on there. Those would be places where I'd say probably we shouldn't be using it, or we're looking very closely at not using a thought record. So that could be, things that some features of borderline personality disorder or things like that, or any other time somebody can't regulate their emotions. And that could be where their clinical anxiety is, more at the severe end, or depression is at the severe end. And I'm also very careful if there's a history of suicidal ideation or self-harm behavior. So knowing your client and knowing your skill level and knowing when to refer and knowing when it's outside of your scope and passing it on to somebody and making those referrals, building a team. Also, when they're able to do the work themselves, when that self-efficacy, when they're able to pick up those self-help books and learn themselves, and we can support them on the outside to answer their questions and support them along that journey. I think that's a really good opportunity to let them fly and flourish with their own, and just act as a guide and an advocate for them. So those may be some of the areas where, or substance use disorders and addictions are another one where we're really careful. So you can see a lot of it depends on the intensity and severity of what's being presented with this client. And you have to have really good clinical judgment and skills to know, is this something I should use or not? Because with each therapeutic intervention, there is, like when you take a medication, you need to know what to expect afterwards, right? So we need to be very considerate of that. So I tend to look a lot at behavioral activation activities, like doing those things and putting them in practice to be able to support them to do some of those other harder things as well. So at least intrusive, but skill and judgment in the moment, knowing their client and when to use it, but certainly understanding those certain circumstances that may make them a higher risk for doing something because they may become triggered.
Great, thanks, Cynthia. I mean, you've just really highlighted the importance of ensuring that nurses receive the appropriate training and education and are competent and recognize their competency before administering, using these strategies with clients. And the critical importance, and I think this is another strength of nursing, is always assessing, is this an appropriate technique for these conditions, for these symptoms, for this client, what else is happening in their life? So a really important reminder. And as we're on the topic of evidence-based strategies to use alongside MI to support the mental well-being of clients, and the use of these types of psychotherapeutic strategies that are drawn from CBT, I'm wondering, Denise or Tricia, if you have any other insights that you want to share with people across the province. As nurses, I'm just thinking as nurses on different teams take up these types of strategies and skills that you want to share in your experiences.
I just want to build on a couple things Cynthia said. So much earlier, Cynthia said it's a parallel process when she was talking about supervision. And I think that, one of the things that's really important in my mind is that not all managers or supervisors have had the benefit of exposure or training to CBT skills, and therefore, the ability to sort of support people who are newly sort of thinking about implementing this into their practice, or even reinforcing for those who have some experience with it. It can be I think that can be a challenge, and I really advocate or put a little plug in for support for managers in doing this. So both in the skills, but like clinical supervision, reflective practice, some knowledge about MI and CBT, and also the pieces around the impact on the whole family and on infants and children and child protection, like as a whole package. And I think that, I have heard some managers and supervisors talk about that they don't feel prepared. They may not have had direct experience as a nurse. They may not be a nurse. That there's a lot of variation, I think, across the province. So, the nurses deserve like good support and in doing this work. And so I just wanted to raise that as I always raise the realities, but as a reality, I think that's something to acknowledge. And then I think the other piece, sorry, Denise, I'll give you, but is that one of the things that we talked about demystifying CBT, like, and you've done a wonderful job of really explaining it very clearly. It was very helpful. But I think that, we need to acknowledge that nurses have been aware of some of the concepts within CBT and tried to incorporate that into MI. So because when you're thinking about automatic behaviors or automatic thoughts, that is, can be a large piece sometimes of what is maybe the challenge in helping a client to develop some insight, or the confidence that they're able to do something differently, or even to see that something can be different. And that to me is all sort of can be part and parcel. So I think you can apply some of this in a itty bitty scale, as well as really exploring the opportunities that we have within our scope to use CBT evidence-based practice. So I just wanted to mention those two things.
Great. And Tricia, this is exactly why I enjoy working with you, is that you bring the reality and what's happening on the ground. And, that identifying that there is a need across the province for support for managers is important to hear, and for all of us who sit at different tables to continue to advocate and see what that can look like. And just, before I move on to our last question, in thinking about the use of these types of therapeutic strategies and skills. We've already alluded to that this fall we will release to all the health units the nursing care plans that really, again, are a focus on what nurses can do, and a really clear guidance for how nurses recognize risk indicators for different types of mental health conditions that occur in the perinatal period, right through to what a nursing diagnoses will look like, to planning, and then in the implementation stage, there's been really careful work to outline which one of these psychotherapeutic strategies will be appropriate for a nurse to consider implementing, depending on the client's score or severity from different assessment tools. So know that we're going to continue to support nurses to develop these skills and think about how to use these strategies in practice. Now, my last question is another question that we often hear in our work across the province, and it's grounded in the reality that nurses are working in the home. They're working one-on-one with clients and families, and that an important part of the nursing process is to identify when referrals to other mental health providers or social care providers needs to happen within the community. So that's a critical part of nursing work, is to identify where there are needs and to initiate those referral processes, often using warm referral processes. But in many communities, there may be wait lists or limited access to community-based mental health resources, or barriers for clients to access different primary care providers. And I'm wondering if, just in your different contexts, how are health units navigating this challenge? And Denise, I started this morning asking you a question. I'm going to come back to you and ask you this question, because you're working in that nursing role. How do nurses overcome these challenges?
Yeah, it's a huge challenge. Lots of health units like ours are having to address that with limited resources, especially for perinatal mental health. So I think first and foremost, we really try to normalize mental health concerns during the perinatal period. So it's something that's actively discussed during calls and home visits with the HBHC team, but then also through our team in health promotion, so different activities and initiatives working together, just trying to help reduce that stigma and really encourage open conversation about perinatal mental health. I think in addition to that, there's just a lot of advocacy that's done around the need for the increased, primary care access here in our community specifically, but also that enhanced perinatal mental health support. So really trying to do our best to raise awareness of these needs that are within the community. Another, I think, really important thing when we're very aware that our community is underserviced is the collaboration with primary care providers and community partners that are here and are actively working towards improving perinatal mental health as well. So our health unit really prioritizes building really strong relationships with those primary care providers, physicians, nurse practitioners, midwives, so that collaboration really enhances those referral pathways and also the resource sharing as well. And then just looking at innovative ways to bridge those gaps. So we do have right now a really well-established initiative where our health unit is supporting maternal mental health by collaborating with a local mental health outpatient program, and that's to offer maternal mental health group therapy. So that's a really great program that we do have here. Of course, a wait list is there as well. But that was something that, was kind of an innovative initiative at the time. Also engaging really closely with various community partners to address perinatal mental health. So there's lots of, early ons and play groups and things like that where it's not necessarily the HBHC nurses that are able to do that at a group level, but our team, for example, is going out and doing that health promotion work around perinatal mental health to collaborate and help bridge that gap with HBHC. And then there's also initiatives, again, by those primary care providers. We've got some new midwifery teams. We've got nurse practitioner-led clinics that have been really instrumental in bridging gaps for individuals that are lacking primary care providers. So there is enhanced access there to those essential services and support. So it's just a really big collaborative effort to try and do the best we can for our community.
Great. Thank you. Some really innovative strategies and also
Mhm.
highlighting the importance. And I think what's always a continuous strength of public health is building collaborations, networks, and partnerships. And Tricia, you work in another community that has, smaller towns, cities, clients probably more geographically spread out. Anything else to add around how nurses are meeting or navigating the challenge when there's wait lists or barriers to accessing other community mental health supports?
I think we sort of approach it very similarly to what Denise described. I think when, like, again, I can compare across like very urban centers and larger and in the north, like when we talk about rural settings, but they're isolated from each other, even like the distance is huge. And so I think nurses play a big role in trying to reduce some of those really practical barriers to accessing the services because the services generally are located in those centers. So I think that's one piece of it. I think that the other piece is one of the things that we thought of to try was so we have underservice in terms of primary care as well. So what tends to happen is we overuse the ER and inappropriately use the ER in some situations with sort of perinatal mental health, and that is not good for anybody. So one of the things we're trying to do is, just because primary care is there doesn't mean that they have, training background or whatnot in terms of managing or supporting a family through this. And so, it's just a beginning step, but we are having Dr. Leishout, I can never know how to pronounce that, come to a community update of healthcare providers and community providers to try to sort of increase that. And one of the things that we experienced in another community that I worked in was there were psychiatrists that were saw themselves as capacity builders for GPs and primary care, so that they would be open to consults around specific cases or that kind of thing, and that just increased the overall capacity. So something like that was really wonderful, and I don't know if communities can work towards that a little bit as well.
That's great. What I love about this discussion today is it's, the sharing of ideas that that all of you have engaged in and ideas that may work for other communities. Now, it's amazing how quickly these conversations go. And in our last few minutes, I just want to quickly turn to some of the questions that remain from the attendees that are here. And Christina, I'm going to ask you this next question, and I'm wondering if you can respond to it, thinking about the nursing care plans that, again, we will share with everyone across the province over the next couple of months. And the question is, specific to HVHC, I'm wondering if other health units have a routine screening schedule they use for EPDS. If so, when have you chosen to screen and why? So I wonder if you can answer that question, and then also maybe speak a bit about the sort of recognition of risk approach that individuals will see in the care pathways when they're released.
Yeah. So the Edinburgh Postnatal Depression Scale, or EPDS, I can't speak to everybody across the province, but there are recommendations around universal screening with utilizing the EPDS in the postpartum period. However, with increased screening, there may be increased early identification. And as we've just kind of had a conversation about being, under-resourced throughout Ontario in terms of mental health supports, I think we need to consider the ethical implications of screening and universal screening when there are significant wait lists or there might not be resources available to support clients identified at risk for moderate or severe depression. So I know within Niagara, our NFP does universal screening because it's part of the NFP process, but Healthy Babies and our Healthy Child Development teams, we have selected to do based on clinical judgment. So really developing that skill set of nurses to recognize risk, potential for risk, also to not when might be it appropriate so that we don't pathologize normal adjustment and transition in the immediate postpartum period, which comes with high anxiety and potential for baby blues. So I think it depends on the resourcing in your community. If you have a well-equipped, community that can handle an influx of early identified mental health concerns, then universal screening might be quite appropriate. But if you're in a resource limited community, I think you need to determine the ethics around that universal screening and shift more toward based on like clinical nursing judgment.
Great. Thank you, Christina, for that comprehensive answer. And Tricia, there's a question in the box that alluded to some comments you made earlier. And the question has been posed is, I'm seeing a greater than ever awareness and disclosure around intrusive thoughts as well as maternal rage, separate from depression or anxiety or other diagnoses. Wondering if the panel has any resources to share on supporting clients in this evolving landscape and assessing risk in nurse decision-making.
Wow, I think Christina or Cynthia could probably best answer that.
Okay. Any thoughts?
Stay tuned for the nursing care pathways. There's quite a bit of conversation or inclusion around, what are intrusive thoughts, and again, what is the distinction between one's thoughts and one's intent to act on those thoughts? Do those thoughts come with fear, guilt, shame? Do they come with a very strong conviction that this is true and I need to act on them? So I think it comes back to building that nursing confidence, their knowledge base of perinatal mental health and everything that it kind of encompasses, and really beginning to kind of tease out, what am I hearing from the client? What are the emotions that evokes in the client? And is it just something fleeting and it's scary, or is it something believable and truthful, and I have this desire to act on it, which then would initiate, your crisis intervention kind of stream of nursing judgment. So breaking that down and what that looks like, you'll see those in those tools coming forward later this year.
And that is a nice note to end on. So thank you for that, Christina. And I would just like to thank all of you. So thank you, Denise and Christina, Cynthia and Tricia, for sharing your experiences and your best practices today as we begin to start this really rich conversation over the next year on how we can best support public health nurses and their managers do the work of supporting their clients who experience mental health issues. So thank you to all of you and wishing everyone else a really great day. Thank you and goodbye.